Hello and welcome to another episode of Medical Today, episode 9, season 3.0. My name is Jared Ratnam, and on today's show we'll be talking about dehydration. That's going to be happening towards the end of the show. Shortly we'll be taking a look at dental care, but for now we want to talk about myopia, which is a growing global problem. And to help me understand a little bit more about myopia and what's being done in order to address this, we have Professor Dr. Sharanjeet Kaur from the Optometry and Vision Science Program, Faculty of Health Sciences, University Kebangsaan Malaysia. Prof, thank you very much for taking time off to be with us. I do understand that you're a very busy person, and it's an honor to have you here in the studio. Well, when we talk about myopia, where do we start this conversation, and how severe is the issue? You know, we all hear about it, that it's a global problem, so on and so forth. But in your view, or from your vantage point, what do you see?
I'll start off first by defining what is myopia. Myopia is actually a refractive condition whereby the distant objects are all blurred, whereas the near objects are seen very clearly. Myopia is actually globally now at the rate of about 30%, but it is projected that by the year 2050 it's going to rise to about 50%. So in other words, every 1 in 2 people will be myopic. So it's actually a very alarming increase, and an epidemic, as already stated by the World Health Organization. It is one of the 5 priority conditions that needs to be addressed urgently. So if you look at Malaysia, or rather in Southeast Asia, the prevalence is about 80 to 90%. Whereas in Malaysia, a study done in 2005 showed that the prevalence in Chinese was about 47%, and in Indian and Malay school children is about 20%. So it's quite high, and it's on the rise.
It is on the rise, and it doesn't take rocket science for one to realize that modernity and technological advances have also led us to the eye problems we have now. So basically what you're saying is, your explanation as to what myopia is the simple fact that you can't see into a distance.
That's right.
Anything close by is not a problem, but looking into a distance is a problem.
Yes.
Now, to further understand this, maybe you can walk us through what extreme myopia is.
There is actually no terminology of extreme myopia. Previously, myopia was classified as either low, moderate or high, depending on the power. But recently, I think in the year 2018, the International Myopia Institute has actually suggested to WHO to reclassify myopia to be either low or high. So if you have a power of less than 6 diopters, which we call it, or 600 in layman term, we would say it's low myopia, and anything above 600 or 6 diopters is considered high myopia. So I guess your extreme myopia refers to high myopia, I think.
Now, coming from the Optometry and Vision Science Program within UKM, are there any researchers or surveys being conducted as we speak with regards to Malaysians and our susceptibility to eye problems?
We have quite a number of studies being done, not only in UKM, but I think there are some studies done by USM also, whereby we are looking at prevalence rates. If we look at intervention studies, I think we have done one intervention study in the year 2017, whereby we looked at the efficacy of multifocal contact lenses and how well it can control myopia. It shows promising results for about maybe 30-35% control, but of course it's not the ideal 100%. Even worldwide, there are many studies being done as looking at how to control myopia. Most of the types of treatments that they have looked at would be multifocal contact lenses. They would look at pharmaceuticals like using atropine or drugs. They have also looked at use of contact lenses, the ortho-K. I'm sure a lot of people would have heard of it. And now the new emerging idea is actually children should be exposed more to outdoor activity.
Right. So therein lies another problem. They say kids need to be exposed to outdoor activity, and then there are other studies that say that kids shouldn't be in the outdoors, especially in climates like ours. So, where do we find that balance?
I think there were some studies done. They showed that if the child is exposed to about 2.5 hours of sunlight exposure per day, it's good for them. So exactly what is the line, I think nobody has come to to consensus yet.
I want to go back to what you're talking about. You're talking about multifocal lenses. It's now in use or on trial, but the things that come to mind would be, I'm a person who wears a multifocal pair of eyeglasses, and there are problems like there are always blind spots. Once you start getting used to them or you start depending on them, you kind of figure out that there are blind spots also. Is this a problem with lenses?
There were studies that showed that if you use spectacle multifocal contact lenses, they are not very suitable for children, because you actually need to teach the children how to use the lenses.
Right, and also the training of the perception of depth, so on and so forth.
Absolutely, yes. So what we are doing now is using multifocal contact lenses. With that, the lens is on the eye, so there is no problem about being able to adjust or learn how to use the lenses. And so with that, there are no blind spots.
Right. So with myopia, it's a progressive thing. Does it stop at some point? Or does it continue? Does it go on to progress?
Okay. When infants and young children are born, infants are born, they always are born with hyperopia, which means short-sightedness, okay? And then as they grow older, the hyperopia will start to reduce. And by the age of about 6 to 7, they are left with about plus 0.75, which is the normal.
Right. So, hyperopia means if you're playing with a kid and you want the kid to look at something, you shouldn't put it too close to his or her face. They won't be able to make it out.
Yes, that's right. Yeah. So as they grow older, the hyperopia will start reducing. But by the age of 6 or 7, if their hyperopia is less than 0.75, then the chances that the child is going to become myopic is very high. Okay. Myopia will start coming in by the time the child is about 7, 8, 9. It'll start progressing. And usually 95% of myopic people will stabilize by the age of 24 years. After that, they'll be stable, and then the power will change again once you go to about 40 years of age.
Right. So it's 2019 now. If you go back 20 years, go back to, say, 1998, did we have problems like these back then?
Yes, the problems were there.
Or has it escalated?
It has escalated. It has escalated by almost 10 times.
Exponentially. Yeah.
Exponentially, yes.
Right. So with this in mind and armed with all the information we have now, what's being done in order to ensure that people are aware about this? I guess this goes back to people being aware as to using technological devices, so on and so forth. So awareness campaigns are very important. What's being infused in these campaigns to create more of to keep it etched in the mind, so to speak?
I think the thing is that when we want to bring forward to the public what needs to be done, we have to go by evidence base. At the moment, there is not sufficient evidence to pinpoint the exact cause. We know that genetics play a part, because if one parent is myopic, then the chance of a child being myopic is about 20 to 85%. If both parents are myopic, the chance of the child having myopia is 30 to 40%. So genetics is one issue. Second thing is a lot of near work. Because in Southeast Asia, the myopia prevalence is about 80 to 90%. Looking at our system of education, so much of emphasis on near work, on getting good grades in tuition, that also contributes to myopia. And it is said that if you do a lot of near work for more than 2.5 hours per day, that's going to contribute to myopia progression. Apart from that, outdoor activity, as I said, so there are multiple factors. So I think all these multiple factors need to be put forward to be, parents to be made aware of, rather than this just pointing on one, because at the moment nobody knows what is the causative mechanism actually.
Now, I don't know if this is the right question to ask, but can myopia be corrected naturally?
No.
No, it can't be corrected naturally.
No.
So it has to be corrected via glasses.
Glasses and other means.
Okay. When you say other means?
Maybe you have to control your near work you're doing, you have to have more outdoor activity. At the moment, that is what we know. In future, I mean, a lot of research is going on, so people are trying to find out what is the actual cause of myopia. Nobody has at the moment come down to the to point the exact cause.
I think for a layperson like me or the consumer, the bigger problem would be options put on our table when we have myopia. What are the options that are out there now, and how do I choose wisely?
Okay, I think the standard practice is you're given single vision glasses, but the current knowledge recommends that single vision glasses should not be the only option. If your child has myopia and a single vision is given at the first instant, and at the second visit the myopia has still increased, then the other options should be thought of, maybe multifocal contact lenses, or maybe pharmaceuticals, or maybe ortho-K, because it's going to progress if you give single vision, because single vision works on the principle that you're only correcting the refractive error at the center of the fovea, the area of the eye which sees detail, whereas the periphery of the retina is still uncorrected. So any image which is out of focus on the retina will cause the eyeball to elongate, and elongation of the eyeball causes myopia.
Right.
So that is why now they go for the multifocal contact lenses. I mean, a lot of people use off-label contact lenses. The one that I use for presbyopic patients, they put it on the children. It works quite well. And some companies have come up with their own myopia control lenses. So that gives a better option to control the myopia.
Right.
So you shouldn't actually just go on for single vision glasses. I think you should go on to a next stage of treatment.
But if you think about it, if you're going to get a child used to wearing contact lenses, it's quite a task, you know, getting it to be inserted onto the eye or into the eye is a bit of a problem for parents. So what's your advice to parents with regards to that? If their child, the only option left is for the child to use multifocal lenses.
Usually we get the parents. If the child can't handle the lens themselves, then the parents are the ones who insert and remove the lenses.
Right.
And I think parents who are really concerned usually do not have a problem with that.
Now, with regards to lenses, I think the conversation that surrounds lenses would be hygiene. People have problems with hygiene, and when you're dealing with a child, and if you have to place the lens, help the child with the lenses, hygiene needs to be of utmost importance.
That's right.
What would be your go-to standard with regards to that?
Well, nowadays we have disposable contact lenses, so I think that shouldn't be an issue. You can wear it and then throw it away.
Yes, wearing it and throwing it away, but you're dealing, washing your hands, making sure the hands are clean before you even touch them.
Yes.
Do you talk to parents about that?
Of course, absolutely. So we go through the whole protocol. We ensure that they know the pros and the cons, how to handle the lenses, and who to seek any help if anything goes wrong. I think all this we do before we actually dispense the lenses.
Now, with regards to the optometry and vision science program, what's happening there? Is that program being expanded? How has that program been running? It's been going on for quite a while now, isn't it?
Yes. UKM has been running the optometry program since 1982, 81. And it is very well established. All our lecturers are PhD candidates, with PhD qualifications. So we have been running the program for a very long time. Apart from that, we also run postgraduate courses. We have postgraduate for clinical optometry. So we are training clinicians to be primary eye care providers at a tertiary level. We also run postgraduate by research, so masters and PhD. So I think we have a lot of things going on in UKM.
A lot of things going on in UKM.
Yeah.
Now, while this broadcast is being recorded, World Sight Day will be celebrated around the time the broadcast is aired. Now, World Sight Day is on the second week of October, which is on the 10th of October in 2019. And in conjunction with World Sight Day, what would be your advice to all of us? You know, there's a lot of things being circulated on social media with regards to our eye health and how most of us take it for granted, especially by buying things without the approval of an optometrist or going to an eye doctor to get our eyes tested, so on and so forth.
Yes. Well, my advice would be that take care of your eyes, because you only have one pair, and you know, if you lose the sight, it's devastating.
Right.
Because without sight, it's very difficult. We celebrate World Sight Day usually in UKM also, whereby we will have people who are interested to come, and we will let them experience how it is to feel blind. So, you know, you can go into a dark room, you have no light, and just try to walk about and see how it is. So take care of your eyes regularly. Yearly get an eye checkup. If you have children, please do take them and go for eye checkups also. It's absolutely important, a yearly eye checkup, even though if the child doesn't have a refractive error at that time. And if the child does have a refractive error, then follow the advice of the optometrist, which would be always correct the eye, because under correction causes myopia to progress even faster. Limit the amount of near work you do. Have a lot of outdoor exposure at a minimum of about 2.5 hours per day. And it's been recommended near work should be less than 2.5 hours at one time. Practice visual hygiene, which is, we call it 20-20-20. So for every 20 minutes that you read, you relax 20 minutes. Yeah? And I guess that's about it. Yeah?
That's about it. On that note, happy World Sight Day, Prof. It was a pleasure and an honor having you on the show. We hope to have you back again to give us more advice with regards to eye health. We just spoke to Professor Dr. Sharanjeet Kaur from the Optometry and Vision Science Program, Faculty of Health Sciences, University Kebangsaan, Malaysia. We're going to take a short break and we'll be back just after this right here on Medical Today. Stay with us. I'm Jared Ratnam.
Do you experience indigestion, bloating, or stomach upsets? You need Blackmore's Digestive Enzymes Plus. Made from natural enzymes and ginger, it helps to break down your food so all the nutrients can be absorbed by your body. Healthy tummy, happy you.
Thank you very much for staying with us right here on Medical Today Season 3.0, Episode 9. I'd like to take this opportunity once again to thank Dr. Sharon from UKM for joining us a while ago to talk about myopia. From there we talk about dental health, and joining me in the studio is a prosthodontist. Now, if you don't know what a prosthodontist is, we're going to get an explanation to that, simply because apparently there are 10 areas of speciality within dental health care. So we're going to try to get some insight as to what a prosthodontist does. And joining me in the studio, Dr. Mohamad Muzafar Hamirudin, a consultant prosthodontist from KPJ Dental Specialist Center. Now, he joins us on the show to give us an insight as to what he does. Doc, thank you very much for taking time off to be with us. A lot to talk about with regards to dental health, because Malaysians are now becoming aware of dental health care. You see, every teenager wants to spot a pair of bracer, and everyone wants to have a good set of teeth like Americans or Koreans. You know, it's becoming a big thing in Malaysia now. Before we move into all that, what does a prosthodontist do?
All right. A prosthodontist, we specialize in replacing the missing hard and soft tissue inside the oral cavity. What it means that we replace the missing teeth or any other structures which are missing. Like, for example, we do crown and bridges, dental implants. Sometimes we do prosthesis, maxillofacial prosthesis, we do replace eyeballs, nose, ears. That is our area of specialty. That's what we do in a hospital-based dentistry.
Right. So within dentistry, what are the common problems that you have to see on a daily basis?
It's always about gum disease, gum diseases, tooth decay, toothache.
Right.
Those are the common problems that we see in the daily practice in our dental clinic.
So when you talk about gum disease, is it just subject to gingivitis, or is there an array of different gum diseases?
When we talk about gum diseases, it always starts with gingivitis. All right, gingivitis is an early stage of gum disease. All right, it may progress further. So once it may progress further, it is known periodontitis.
Right.
So gingivitis becomes periodontitis, where you're going to start losing your bone and your gum. So that's where you see there's a gum recession occurred.
Okay, so why are we having, or why are Malaysians suffering from gingivitis? What it is that we're not doing right?
Well, it's all about hygiene. All right, gingivitis starts with the cause of the gingivitis is always because there's in our mouth there are bacteria. There are specific bacteria can cause gum diseases, especially gingivitis. So the aim is we always advise our patients to improve their hygiene technique so that you can reduce the number of bacteria. Then further on, you can actually reduce of getting the risk of having gingivitis.
Now another interesting point is the fact that you talk about hygiene, and there are lots of different versions of what we can do to maintain dental hygiene. So some say, or the go-to standard is brush your teeth twice a day. Some are saying that you need to do it after every meal. Then once you go back, you have dentists who say you're over brushing your teeth. And so where's that balance? Where do we find that?
All right. It's for me, if you ask me, well, how frequent do you need to brush? What are the techniques? What type of toothbrush? Well, we always advise our patient to brush your teeth 2 or 3 times daily. But the most important thing is the technique. It has to be effective. All right. Then only you know that you're going to reduce the number of bacteria by using the right technique, the right toothbrush. Toothbrush. When I said about toothbrush, you have to use a soft toothbrush. So that you don't actually traumatize your gum.
I'm going to hand you something where you can show us a little bit more as to, when you say talk about good technique, what is good technique, and then we're going to talk about crowns and bridges.
Well, techniques is quite difficult to show it on in this model without a toothbrush.
Okay, without a toothbrush.
Usually, what I will advise my patient is to hold your toothbrush, angle it 45 degrees towards the gum and the neck of the tooth.
Angle it 45 degrees.
Yeah, angle it towards the tooth.
So it's 45 degrees this way or this way?
This way.
This
and then it goes. This is upper. Assuming this is a lower teeth, so you got to angle it 45 degrees towards the neck of the teeth and towards the gum, and then you just wiggle it softly up and down and scroll it, gently.
Gently.
All right. Take your time. All right. It doesn't mean that you brush hard. Yes, of course you clean your teeth, but you might lose your tooth structure by brushing too hard.
Right.
All right. So you've got to spend time brushing. Use your soft toothbrush.
So for me, it's when you talk about hygiene, I go to see my dentist, and my dentist says, Gerard, no, you're sort of losing bone, probably because you're brushing too hard, and you say these problems come from bad oral hygiene. So I'm thinking, do I have bad oral hygiene?
All right. If you come to well, if you're going to see any dentist, I think they should be able to come up with a race investigation. So they have a pool of questions, things that you need to do. You need to put it in your small little diary, what you have taken, what is your regime of toothbrush techniques. From there, we can actually assess.
Right.
So what is the causing factor? What are the risk factor? Which cause your problems?
Right. Now another interesting fact that I've come across, and I thought which should be brought up, is the fact that a lot of people now suffer from GERD. Okay, and with GERD, you have a kickback of acid into your mouth, and that somehow pushes into your oral hygiene.
Yes.
And it's also very corrosive to the teeth.
To the teeth, correct.
Okay, so do you work with gastroenterologists in conjunction with helping people?
Oh yes, for sure. Yes, when we call it dental erosions due to the GERD because of internal acid. All right. So we always work together with the gastroenterology specialists, where we need to work together with them so that we can actually reduce the impact of acid to the teeth.
Right.
If the effect to the teeth is too damaging, then we come in and to restore, to protect the tooth with crown and bridges.
Right.
Some cases, it's severe. It's very severe. You can see the teeth are being flattened due to acidity coming from the the
So I guess at this juncture, for those of us who have GERD problems, most of us develop GERD from stress, so on and so forth. You really need to take care of what's happening to inside of your mouth with regards to that, right? We worry about what's happening here in the chest and in the throat, but we're not worried about what's happening in the mouth as soon as we get an attack, so on and so forth. Now, moving into something more interesting, I'd like to talk about dental bridges, caps, and also crowns. You know, some of us, we know what it is, but we get the wrong pictures in our mind as to what a crown is, what a capping is. So maybe walk us through that.
All right. Crown, this is actually a crown.
Right.
Crown, well, in layman's term, we call it capping.
Can you put it up a little bit just so we can see it?
This is the one,
Okay.
Okay, we're gonna. So this is actually a crown.
Okay.
All right. So it is also known as a capping. All right. So it is actually interchangeable. All right. So we use crown mainly to protect the teeth. All right. Because some teeth are badly broken due to decay. Then some teeth are badly broken due to trauma, or some of the teeth required to do root canal treatment. So crown comes in to protect, to give a good seal and enhance the what I call the success rate.
So if you're looking at this now, do you mind if I hold it?
Yeah, sure.
So if I pull this out, this happens to be a crown, So
correct.
If your teeth is flattened out or it's small, now what we need to do is just put this on, and that becomes, voila, your crown.
That's a crown. It is being cemented to the tooth.
Okay.
All right.
So something like this, a crown, how long would it last for? You know, does it last you a lifetime, or are there different grades?
All right. What I will always tell my patient, nothing lasts long in this world. Well, but anyway, there's a good evidence. People are looking, the researchers are looking at longevity study. They are looking at more than 36 years now.
Right.
So it's there. It's good. It has got a good long track record, but depends on type of crowns. Because in the market, in dentistry, there are a lot of types of crowns. Sometimes they are made of, this is actually all porcelain. All right. The other type is porcelain fused to metal crown. Okay. But you can see here,
porcelain?
there's a metal.
Okay, can we put this up? Porcelain fused to metal. So if the camera can get this, you know, we're going a little closer. A porcelain, which is rather porcelain on the outside, fused to metal, to make it a little bit more hardy in it.
Correct. It's a metal core inside. All right. And
so that's still a crown, huh?
That's still a crown.
Okay.
All right.
What is a bridge now?
Bridge now, we use bridge is to replace any missing teeth. Okay. For example, there's a missing tooth there in the middle, right? So what we need to do, this is actually a 3 units conventional bridge. We have to do some preparation to the adjacent teeth. Okay. We have to grind the teeth, both teeth, one over here and one over there. All right. And then once it's done, we're going to take a mold, send it to the lab. All right. And then the technician will fabricate the bridge. Right. And then once it is ready, then the bridge will be fitted in, cemented, like crown.
So looking at the bridge, two stronger teeth holds the teeth, the area without a tooth with another supporting teeth. But I guess the problem there would be you wouldn't be able to clean your teeth on that side.
Yes, correct. It'll be tough, but there will always be a way. So I will always advise the patient to use super floss. It's a special floss. It has a rigid end at the end of the string of the floss. There's a rigid end. That rigid end goes in between the bridge, underneath the bridge. That's where you floss underneath the bridge. Use super floss. Super floss can, the only floss that can do is super floss.
Here's the other question. A lot of us, when we go to the dentist, we get the crowning done or capping done, so on and so forth. What happens after that is, maybe after 10 years or maybe after 6 years, it starts to hurt on the inside. What's happening there? Because a root canal has already been done, the procedure has already been done, the cap's been put on or the crown's been put on. What's happening inside there? Is there an infection? what can go wrong?
All right.
After you spend a lot of money. So.
Okay, definitely not money, eh?
Okay, not money, not money.
Okay, so what happens? The common problem with the crowns is always when you cement the crown of the tooth, there will always be a micro gaps. That's where the bacteria can go in. We can't close the gaps.
Right.
All right. But nowadays, with the current materials, technology, we are minimizing the gaps. The gap will always be there.
Right.
So what happens when there's a gap? So the microorganisms can be seeped through. Then it can cause what we call a secondary decay underneath the crown. So the secondary decay might trigger infection to the tooth, or to a root canal treated tooth.
Right.
So that is always the cause.
Right.
All right.
But with any problem with your teeth, I mean, if the gums are receding, if the teeth or the tooth becomes shaky, something can be done about it.
Something can be done depending on how severe it is. If it is too shaky, well, my advice is always to take it out, depending on the grade of the mobility of the tooth.
Right.
It depends. It has to be assessed in the clinic. Yeah.
Now, you wanted to talk to us. So you did mention that you want to talk about the Ellis classification. Maybe walk us through what it is.
Okay, Ellis classification, we use it to classify dental trauma of a tooth.
Right.
All right. It has 8 classifications. All right. It's going to be it has 8 classification. Classification number 1 is when I'm going to use the diagram.
Right.
There.
Sure. Go for it. Yeah.
All right. Here. Okay. If the fracture involving enamel.
Maybe if you can hold it up a little bit, we don't get it clear. Yeah.
All right. Type 1, when you have a fracture at the outer layer, enamel layer, that is a type 1 classification of Ellis. Type 2, when you have a fracture at both layers, enamel and dentin, right? Just right across there. That is class 2 classification of Ellis. Class 3, when you have a fracture involving 3 layers at the same time, where enamel, dentin, and pulpal area.
Right.
So there will be exposed of the pulp of the tooth. That is classification number 3. Number 4, when there's a classification number 4, when there's the tooth, because of the trauma, the impact, the tooth will become non-vital. It means that the nerve inside the tooth is dead. It's non-vital. Right. That is classification number 4. And then number 5, when there's a fracture of the root, the impact is coming from the top. The fracture is somewhere at the tip, at the root area. Right. So that is 5.
Okay, so here you've got 5 different classes in the Ellis classification.
Yeah, it is 8 actually.
It's 8.
It is 8. Yeah.
So the 8 different classifications there, and I mean, for those of us who want to know more about what the Ellis classification is, what you do is Google Ellis classification. That's ELLIS classification, and you'll get all the information you need. Now let's go back to different problems like infection in a dental abscess. What are these? How do these problems come about, and how can you help with these problems?
Right. When we talk about dental abscesses, we need to know the cause. Where is the cause? So sometimes we have to assess the cause. Usually it comes from is either from the tooth or the gum. Right. That is something we have to do a special test in the clinic. Lots of radiographical examination to detect the source of the infection. All right. So when you have dental abscess, the abscess is always the pus is actually trying to find out the easiest way to come out. All right. That's why in most cases you can see gum boils. All right, inside the gum. That is also a dental abscess. But in the severe cases, the pus is trying to very hard to find its pathway going out from the source of infection. So it goes into spaces, into the neck. So it starts to swell up in the neck, at the orbital area. So those are the things that you have to be very careful. Watch out for.
So the other part of the mouth, which is the inner part of your cheek.
Correct.
Okay. Most of us through biting, and we sort of injure this a lot, especially when we're eating. You know, we kind of injure the back of our what do you call that? The side, the cheek. Yeah.
All right.
What can be done about that? Because after a while, it starts to become bumpy and it starts to stick out. It starts to, for some people, it starts to interfere with their biting.
With the biting, all right. Most of the time, it happens with those wearing dentures. All right, because that is something we have to adjust the alignment of the teeth, because sometimes it's just too sticking out. So when you chew, then you might accidentally chew. The patient might accidentally chew on the cheeks, so that it might traumatize. So we need to adjust the alignment of the teeth. Whereas for a dented patient, all right, we got to look. We have got to look the way you are biting, the occlusion. That is something we have to look at. Sometimes we have to do a minor adjustment to your teeth, all right, to correct your alignment.
Right.
Most likely orthodontically, you've got to wear braces, right?
Right.
Yeah,
right. So now I guess for a lot of us now we really learn to understand that our teeth, or the set of teeth that have been given to us, is sort of the pride of our lives, and
correct,
a lot of people are now very much into looking after their set of teeth. You doing what you do as a prosthodontist,
correct.
What kind of advice would you give us with regards to oral health, with regards to keeping your teeth good? And a lot of us want to opt for whitening, veneers. We all want to try to look good. It's never happened before in Malaysia, and now we take this very seriously. What would be your advice to us?
All right, this is what we call cosmetic dentistry. All right, I'm not really into cosmetic dentistry. My advice is...
But you provide the structure for cosmetic dentistry.
Yeah, I provide but we have to assess the patient. What do they really want? Do they want to have a straight teeth? Do they want to have a white teeth? So there will always be a few options. So they want to have if they want to have a whiter teeth, we can always start with which is very conservative, like dental whitening. All right, you can do that first. But some patients, they want to have a straight teeth, white straight teeth. So sometimes we have to combine treatments like orthodontics, veneers, and bleaching. So it depends what the patient wants. All right, that is something we have to assess.
Right.
All right. So we always start with something which is very conservative. Teeth whitening is always first in the line.
Right.
Or perhaps those who are going for a straight teeth, they should be going for braces, or orthodontics management.
Right.
Or in extreme cases, they want to have a Hollywood smile.
Yeah, of course. I want to have a Hollywood smile.
So you're talking about veneers. So veneers is just a layer of porcelain which is being stuck up on the teeth. But with doing that, what happened that in the clinic, what we have to do is not sometimes, I think most of the time, we have to grind a little bit of your tooth structure. Right. All right, before we can actually fabricate the veneers and then stick up the veneers. So we've got to create space for the veneers.
Right.
That's why we have to grind the teeth away a little bit.
Right.
All right. Yeah.
Well, with regards to veneers, I'm not a big fan of it because I see that some of us appear to be whiter than white, when we wear veneers for some reason. Yeah. But having said that, I guess the other thing we haven't talked about is, if your teeth gets knocked off through trauma, playing sports, motorbike accidents, so on and so forth, and if you're a young person, you might want to do something like an implant. Now, what is an implant? How is it done? And how much would it set you back cost-wise?
All right, okay. Implant is actually... it has becoming a #1 option to replace a missing teeth because it is actually a well-documented procedure. It is actually pretty safe, pretty highly predictable in terms of success rate if it is done and planned properly surgically. All right. So I must say, if you ask me about what is the success rate of the dental implants, it is actually pretty high. You're looking about 90%. All right. So the good thing about implants comparing to dental bridging, remember what I said about dental bridging? When you opt for dental bridging, you have to grind the teeth.
Correct. Yeah. Right? So the teeth on either side.
On either side has to be grind to create space for the dental bridges. Right.
There's a question that's coming in from the producer.
All right.
And apparently, someone's called in to ask if dental bridges last forever. Okay, so we receive mails every now and again, and we did receive a mail asking this question: does the dental bridge last forever?
That's a good question. Nothing lasts forever. I always tell the patient, nothing lasts forever.
That's an easy answer, Doc.
Easy answer, yes. Nothing lasts forever, but we have to back it up with research, all right? So research, because we have been using dental bridges for the past 30 years. So people are looking at 26 years of study, and it's still going on, all right? So the success rate is pretty high and predictable with dental bridges. But the only problem with dental bridges is that we have to grind the adjacent teeth.
Right. So the boys on the side need to be sacrificed in order to work with that one empty space, right? Yeah. I also do understand that you work with cleft palates, so on and so forth. Yeah. How much of work do you do in that area?
All right. Cleft palate is actually a multidisciplinary approach. All right. We work with the medical colleagues, with ENT, plastic surgeon. As a prosthodontist, we only come in when the patient reaches adult stage, where we have to do a full mouth rehabilitation, where the missing teeth are. Right. Well, if you ask me, the dentist will come in to look after the child when the child is newly born. The first person to see in dentistry is always the pediatric dentist, because they will always help the child to the child will obviously have a problem in terms of feeding because of the cleft lip and palate. So they will come in to help to fabricate what we call a feeding device to help the child to do the sucking during the breastfeeding. So that is the area of pediatric dentist. And then when they reaches the age of teenager, then the orthodontist will come in to look after them. And then for myself, as a restorative prosthodontist, will come in at a later stage to help the patient.
So you come in at a later stage, and when you come in at the later stage, what, as a prosthodontist specialist, what do you look out for? I mean, the guys before you need to lay the proper groundwork in order for you to have something good to work with. So how do you work in conjunction with each other, or how are notes passed on from the baby as it becomes a child, adolescence, it moves on further, teenager to an adult? Are there records by the previous doctors for you to work on?
This is what we call escalation of management. It starts from the baby, all right, until they reaches adulthood stage. So we have to work together. For me, the previous dentist, the previous specialist, they have to create space for me, all right, and then create space for me to replace the missing structure. We have to plan all that, all right. So because in the cleft lip and palate, usually you have a few or several missing teeth. It's always at the front. So the orthodontist will create space for me to create to give a nice even space for me to fabricate my prosthesis. All right. That's how I work with the rest of the team. All right. So that's what I do with the cleft lip.
With the cleft lip. Yeah, well, it was a pleasure having you in the studio. And before we end the segment on dental health care and also understanding what a prosthodontist does, what's your message to the rest of us with regards to anything, visiting a dentist perhaps, with regards to buying toothpaste, anything and everything? Every little piece of advice is good advice coming because oral health is so expensive these days. And
it's expensive. Correct.
Yes.
Yes and no.
Yes and no. Okay. All right. I know where you're getting with this one.
Maintenance is.
While it's expensive, it's cheap here.
It's
seriously.
Cheap, exactly. Maintenance is very cheap, but neglect is very expensive. All right. So my advice is take care of your teeth, and then treat your oral cavity as a window to the rest of your system of the body, of your body. So it is actually a very important organ you have to look after. Then see your dentist regularly, because sometimes we do see patients 3 monthly, 6 monthly, 12 monthly. It all depends on the risk. All right. But my advice is please come and visit at least once in a year.
Once in a year. So it's a very simple advice. Your oral cavity is the window into the rest of your body. take care of it. It's
Correct.
as simple as that. On that note, Dr. Mohamad Muzafar Hamirudin, consultant prosthodontist from KPJ Dental Specialist Center. Thank you very much for joining us. It's a pleasure having you on the show.
Thank you very much.
Of course, thank you very much for joining us. We hope to be with you on the next episode with more. And of course, having said that, we're going to come back with another segment very soon, and to tell you what's happening in our next episode, all happening right here on Medical Today, Season 3.0. This is Episode 9.
What you put into your body today will shape your life tomorrow. So be sure of good health with Blackmores. Begin better every day with Blackmores.
Thank you for staying with us. This is Episode 9, Season 3.0 of Medical Today with me, Jared Ratnam. And we're quick coming to the end, but in this season, as promised, every week we bring you a little video about first aid mistakes. And today, we're going to be talking about dehydration. Now, it's a big problem. A lot of us have problems with dehydration simply because we are losing our ability to understand what thirst is. So our thirst mechanisms are somehow out of sync, or at least for some of us. Now, dehydration is a big problem, especially if you're living in a country like ours in the tropics. It's a little something we need to take heed of all the time, is to ensure that we keep our water levels up. Now, here's something we always do when someone's dehydrated, or we believe that someone's dehydrated. We give them a fizzy drink or soda. Is that the right thing to do? Now, we have a video for you as to what you can do. Let's take a look at this video.
The mistake: giving a dehydrated person soda. You can become dehydrated for many different reasons. It could be from sweating too much. Vomiting or diarrhea can quickly remove fluids from your body too. By quickly getting a parched person something or anything to sip, you're making things worse. Avoid coffee, tea, soda, and diuretic drinks, especially alcohol, because they can dehydrate you more. Do this instead. There's really only one way to treat dehydration. Replace the fluids and electrolytes your body has lost. Water is your first choice, but there are lots of special drinks on the market that will help you replace your body's lost water and electrolytes. You can also alternate between 4 ounces of water and 4 ounces of Gatorade every 15 minutes while resting somewhere cool. If you don't feel better in half an hour, don't wait. Call 999 immediately.
There you have it, a video for you on what you can do if someone is dehydrated. Now, remember these simple things. Do not give a dehydrated person coffee or tea, alcoholic drinks, or even soda. Well, it sounds funny at times, but shouldn't be doing that. The go-to standard would be water or just H2O. Please think about this. And always, if you're in a situation where you can't handle whatever is happening or an emergency situation, please call our friends at 999 and let them walk you through what you can do to best assist in an emergency situation. or if you are triaging. On that note, if you do have any information for us, or if you'd like to request for us to have someone on the show, please send us an email. Send it to ask@medicaltoday.my. That's ask@medicaltoday.my. Next week, we have yet again another fantastic show coming your way, and we'd like for you to join us then as we bring you another episode of Medical Today right here on BNC. This is Season 3.0. I'm Jared Ratnam signing off for this week.